Looking at the esophagus, they are very important. Of course, some of the things that you are likely to feel, the symptoms that or complaint that somebody is likely to come out with if they have a problem with the esophagus would be maybe pain on swallowing, we call it odinophagia, or difficulty in swallowing, we call it dysphagia. So dysphagia is difficulty in swallowing. Odinophagia is painful swallowing. So especially if somebody has painful swallowing, then you start thinking about infections or inflammation within the esophagus. If somebody comes with maybe just difficulty in swallowing, then you start thinking about tumors within the esophagus. You start thinking of esophageal cancer, for example. Yeah. So generally, infection of the esophagus is rare in healthy individuals. So if you are healthy, infections, whether viral or bacterial infection of the esophagus should be, is usually rare. A debilitated or immunosuppressed patient infection with herpes simplex virus or candida albicans is common. So in debilitated patients, basically patients who are very sick or people who have immunosuppressed, like maybe somebody who have HIV or AIDS or other things that will cause your immunity to go down. So these are the people that are likely to be affected, for example, by herpes simplex virus or Candida albicans. Candida albicans is a fungal infection. It's a fungus. Candida albicans is one of the fungus. I'm sure we probably will look at it in microbiology, fungal infection. So you can have fungal infection. You can have candidiasis in the esophagus. You can have candidiasis in the esophagus, just like you can have it in the mouth, just like you can have it in the vaginal canal. You can have candidiasis. Um, then, of course, esophagitis will suggest inflammation. So if there is infection by even virus or candida or anything, you can even have esophagitis from chemicals. If you are to swallow, for example, acid, it will corrode your esophagus and you end up with esophagitis. Of course, even the esophagus also can be affected by ulceration. So if you have an esophagitis inflammation that is not well controlled, or you swallow acid and so on, it's likely to corrode the epithelium of the esophagus and you end up with an ulcer. So you can have chronic peptic ulceration. And most of this would be also due to reflux disease. So you can also have gastroesophageal reflux disease. That is basically in the esophagus, we have the upper esophageal sphincter. That is the sphincter in the upper esophagus that should be able to, of course, open to allow food to get in, but also down just before it through, just when it's going, when the esophagus is going through the diaphragm, we have the lower esophageal sphincter, which is usually a functional sphincter. That means you don't see any obvious sphincter there, but that should be able to prevent acidic content of the stomach from coming up into the esophagus. And so that is what we call, so when you have gastroesophageal reflux, it means that lower esophageal sphincter is a bit incompetent, that is not functional as it should. And then and that is what allows the gastric content to come up, which is acidic. Yeah. So that's what we call gastroesophageal reflux disease. And then the Barrett's esophagus, I'm sure you mentioned it somewhere, Barrett's esophagus. So one of the things that you will probably, people will come complaining of, someone will come and say, I've had heartburn. That is basically they have retrosternal pain or discomfort. Yeah. So basically, because that's what we will describe as heartburn in a layman's language. So mostly this results from there is what we call metaplastic glandular intestinal epithelium at the lower end of the esophagus. So we call it columnar metaplasia. After we talked about metaplasia, that is basically a change of one adult cell to another one. Mostly the esophagus, the entire esophagus mostly should be made of stratified squamous epithelium. But then there is chronic reflux. It will irritate that lower part of the esophagus, and that epithelium will change into an epithelium like that of the stomach, which is usually columnar. So that change, we call it columnar metaplasia, or we can call it glandular or intestinal metaplasia. So if you are to look at the microscope, that is, if you are to take the tissue of that esophagus that is affected by the Barrett's disease, you will see infiltrate, you will see lymphocytes inside the tissues, plasma cells with occasional lymphoid aggregates. That is basically chronic inflammation. So you will see chronic inflammation. And then you will have goblet cells. Usually goblet cells should not be found within the wall of the esophagus. But in this case, you are likely to get goblet cells. And mostly goblet cells will be found within the stomach epithelium and even the duodenum. So you will be able to see patchy distribution of goblet cells. And that will tell you there is that metaplasia that has occurred. It usually is a premalignant condition. Where a premalignant condition, that is dysplastic, it's likely, if it is not dealt with at this point, it is likely to progress to become malignant, that is cancerous. And of course, if you are to look at it, there will be dysplasia. There will be dysplastic changes may be present. This is looking under the microscope. So remember, generally in pathology, you can see something grossly, you can see something under the microscope, that is histologically. Dysplasia again, which you already mentioned, so you are likely to have those symptoms of heartburn, that is retrosternal pain or discomfort. And if you are to look under the microscope again, you are likely to see a typical epithelial cells. Remember, in the esophagus, there should be certain specific epithelial cells, that number ones. So if you look at this, they don't look typical. That's what they call atypical epithelial cells with pleomorphic. I know we described pleomorphic last time, so go back and look at it again. Nuclei. Yeah, and there will be also architectural distortion, increased mitotic activity. That is, the cells are really multiplying at an increased rate. So you will find a lot of cells that are not mature enough. So that's what we mean by basically mitotic activity. So there will be a lot of mitosis taking place at that point. Then, of course, the big one, esophageal carcinoma, a common one and quite a dreaded disease, esophageal carcinoma. One of the reasons is because most of the time we discover it late. Most people, because mostly the initial stages, it rarely is painful. It's not painful. So most people will come to hospital because now they have dysphagia, difficulty in swallowing, because basically the tumor has grown and blocked the esophagus, the esophageal lumen. And that is what most people come to hospital because of difficulty in swallowing. So they will tell you, I have difficulty in swallowing. Maybe initially they were able to take ugali like everybody else. Then slowly they can't be able to take, they have to take a very soft ugali. At some point, they're only able to take uji. At some point, they can only take maybe tea or milk, that is liquids. And even the very severe ones, somebody is not able to swallow anything at all. They are not even able to swallow their own saliva. So they are just drooling saliva. So the challenge with esophageal carcinoma, and we always see them in the district hospital here, because we do a lot of OGD here. Most people will come late when it's already there. What brings them to hospital is because of difficulty in swallowing. That means nothing can pass. So this esophageal carcinoma can be squamous cell carcinoma most of the time, or it can be adenocarcinoma. So mostly adenocarcinoma will arise in the Barrett's esophagus, which we've already talked about. That esophagus that become abnormal because of maybe the reflux of acid that is persistent, not well controlled. So there is that metaplasia. So most of the lower end of the esophagus, 50% of the esophageal carcinomas in developed countries. So this adenocarcinoma is common, around 50% in developed countries. Most of the carcinomas, the esophageal cancers, will be adenocarcinomas. And they are very poor prognosis. That is, prognosis is what will happen. So because most of the time, especially in our setting, we find the people quite late. They come to hospital quite late. As I told you, by the time somebody has difficulty in swallowing, it obviously will be late. So in other countries, they encourage people are able to go early, even for investigations like OGD and so on. And so they're usually discovered early. But generally in our setting, even from my practice over time, most of the time we see them very late. By the time it's obstructing the esophagus, it is too late. Yeah, there's not much you can do. So that's why the prognosis is usually very poor. So lower esophagus may also be involved by local spread of adenocarcinoma of the upper stomach. Remember the stomach, because it's glandular, the tissue in the stomach, the epithelium will mostly be glandular. It can extend, as in it can spread from the stomach, the upper part of the stomach, to enter the esophagus. And so you can have adenocarcinoma that is originating from a cancer actually of the stomach. So patients with long-standing Gastroesophageal reflux disease are at risk of developing adenocarcinoma of the esophagus, which I've already said. Then esophagitis, inflammation of the esophagus, resulting probably from Barrett esophagus. Without, you can have Barrett, so you can have esophagitis initially, so it can progress like this. You initially have esophagitis, that is inflammation of the esophagus. Then it goes on to become Barrett esophagus, that is that change with dysplasia. Then you move on to have low-grade dysplasia. Then it moves on to have high-grade dysplasia, and finally it becomes invasive carcinoma. That is why if you're able to discover it early at the level of esophagitis, then you probably can be able to deal with it and be able to stop the progression to invasive carcinoma. So high-grade dysplasia is a premalignant condition. So if you are to discover also at high-grade dysplasia, then you can be able to do something about it, because otherwise high-grade is a premalignant, and if something is not done about it, it will automatically progress to malignancy, that is cancer. And usually when we do endoscopy and we see somebody with Barrett esophagus, we usually have to monitor with endoscopy. That is, we have to repeat esophageal gastroduodenoscopy, that is endoscopy, maybe every year, every 2 years, depending on the protocol. And then depending on that protocol, you can have, so you have to monitor them with endoscopy and even biopsy. So you have to, when you monitor them, you take a biopsy and go look at it, so that if it turns into malignant, then you can do something about it early. So this one is more common in men over 50 years of age. The risk factors of this esophageal carcinoma would include heavy smoking. So somebody who is a heavy smoker, alcohol consumption, the excessive alcohol consumption can be a risk factor, or is thought to be a risk factor. So risk factor is something that is thought that if it continues, it's likely to lead to. So it's not like confirmed completely. And also food contaminated with fungus. Yeah, so you see that is why, for example, storage of dry, food crops, for example, like maize, beans, you're supposed to be able to store it in a way that it will not be contaminated by fungus. You've heard of aflatoxin. There were people, I think, who ate maybe maize that was contaminated by that fungus, aflatoxin, that caused problem. So, so if it is contaminated, then we thought that it can lead eventually to development of esophageal cancer. So nutritional deficiency of vitamins and trace elements is also thought that it can be a predisposing factor. And also, of course, Barrett esophagus, esophagitis is also thought to be a risk factor, or something that can predispose to somebody developing esophageal. So, of course, these are some of the things that we probably need to deal with if you try to avoid. If you smoking, alcohol intake, you should be able to try and avoid them, so you'll hopefully be able to prevent. However, as I said, really you can't be sure what exactly, because those are risks that are thought could be risk factors. Here, you can see this was actually OGD. OGD is esophageal gastroduodenoscopy. It's upper GI endoscopy, where you use a camera to go through the mouth into the esophagus. We usually go all the way to the second part of the duodenum, looking at the wall from inside. So this one was of an actual patient that we did here in the county referral hospital, and had a cancer of the esophagus. You can see that tumor, and it was completely blocking the esophagus at that point. We couldn't go beyond there. Of course, we took a biopsy of that mass to confirm the histology. So this is a patient who came with an ability to swallow completely, because it was completely blocking the esophagus. So that was an actual patient that we did here in the district. Yeah, so that will be esophageal cancer, esophageal tumor. Of course, you need to take a biopsy so that it confirms to you which kind of cancer it is of the esophagus. But definitely that was esophageal tumor or cancer. And then, of course, we have the appearances, that these are diagrams showing how they will likely to appear. So you can have one that is polypoid, fungating type, that is growing into the lumen and almost completely blocking the lumen. So most of them will appear like that, polypoid or fungating type. You can have one that is causing an ulcer. So it's growing into the lumen and causing a wound within the esophagus. So that's what we call ulcerating type. You can have one that is diffuse infiltrating type. So it is just infiltrating into the esophageal wall. And you can see it's not affecting the mucosa, but it is inflating around the entire. And so basically it will uniformly narrow the esophagus. That is the diffuse infiltrating type.